Good day, everyone. We are the Group 3 and we are here to discuss on the overview and revised classifications of seizures and epilepsies. So to start with, allow me to discuss briefly on the history of these classification before it turned out to what it is today. During the earlier years, seizures and epilepsy types were not distinctly recognized until the year 1969 by a man named Henry Gusteau. So he came up with his own classification, but then it was being resisted and not acknowledged by the people. Not until the year 1970, when Gusteau's classification was recognized internationally and is widely used. Fast forward to the year 1981, when the ILAE, or the International League Against Epilepsy, published a classification of seizures, which was made up of two classifications, the partial and the generalized seizure. So when we say partial, it is an epileptic seizure in which the first clinical and EEG changes indicate the initial activation of a system of neurons limited to the part of one cerebral hemisphere. And when we say generalized seizure, it is in which the first clinical changes indicate initial involvement of both hemispheres. So next, during the year 1985, there was a proposal of epilepsy classification by the ILAE, which is now then influenced by the advances of technology, most especially the video recording with simultaneous EEG. So during this year, there was idiopathic and symptomatic seizures. So when we say idiopathic, there is no underlying cause, then a possible hereditary predisposition. And when we say symptomatic, this occurred because of a known disorder or a lesion. And in the year 1989, this classification was revised, wherein they added the cryptogenic epilepsies, which were like symptomatic epilepsy, but a cause was not identified. It was also during this year that the concept of an epilepsy syndrome was introduced. So in the year 2005, they updated the definition of seizure, which is a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And in the year 2014, they redefined epilepsy as a disease and not a disorder to emphasize the importance and impact of epilepsy. So in the recent years, in the year 2017, the ILAE came up with the Operational Epilepsy Classification System, which aims to define seizures and epilepsies by classifying them using key clinical features, EEG findings, imaging, and genetics.
Now we'll be discussing the updated seizure classification. Well, focal seizures differentiate from generalized seizures in that these are seizures that start in one area of the brain, then can progress to generalized seizure, which affects both sides of the brain. So this can be classified according to the patient's level of awareness and the first most prominent motor or non-motor features of the seizure. And the final classification is whether it evolves to a bilateral tonic-clonic seizure. So one of the factors for this is awareness. So awareness is usually defined as if the person knows who they are and what is going on in his or her surroundings during the seizure. This doesn't usually mean that they know that the seizure is taking place. So if their awareness or consciousness is impaired, then it would be called a focal seizure with impaired awareness. And this is usually caused by secondary or depressed subcortical arousal systems, which lead up to the deep sleep in neocortical region, which would result into impaired consciousness due to there being subcortical and cortical structures being involved. And focal aware seizure, the term focal aware seizure has replaced the term simple partial seizure, and focal impaired awareness seizure has replaced the term complex partial seizure. This is just for specific reasons, so we can pinpoint and differentiate from a generalized seizure. So now we will be talking about focal motor seizures. So this is usually focal motor seizures with motor onset manifestations. So this could include automatisms, and some examples for this would be oral automatisms, which include lip smacking, panning, etc. And epileptic spasms, atonic, clonic, hyperkinetic, myoclonic, or tonic. So focal atonic seizures, this is the loss of muscle tone in one body part. Clonic seizures, which is repeated, regularly spaced, stereotypical jerking movements. Hyperkinetic, which includes excessive muscular movement seizures, which include thrashing or pedaling. Focal myoclonic seizures, which include irregular non-rhythmic jerking. Tonic seizures, which include motor seizures with increased tone or stiffening of the limb. First prominent features of non-motor symptoms symptoms include autonomic, behavior arrest, cognitive, emotional, or sensory seizures. So autonomic is when there's changes in autonomic functions in the body. Behavioral arrest is when there's cessation of movement, which we can see when the patient begins to have a blank stare or cessation from talking or moving. And then we have non-motor cognitive seizures, which include changes in the language, function, thinking, or associated higher cortical functions. Then emotional seizures, which include clear emotional changes with the following emotions displayed here. And then the focal sensory seizures, which include the changes in sensory phenomena. And finally, features used in this the final feature used in this classification is if the focal seizure evolves to a bilateral tonic-clonic seizure.
So we have the generalized seizures. Generalized seizures are classified according to motor and non-motor manifestations. Motor seizures are either tonic-clonic or other motor seizures, and non-motor generalized seizures primarily refer to absent seizures. Motor onset seizures include tonic-clonic, clonic, tonic, myoclonic, and myoclonic tonic. Generalized tonic-clonic seizures last for 1 to 3 minutes and result in immediate loss of awareness and consciousness. The tonic phase is the stiffening of all limbs and the tongue may be bitten during this phase. The clonic phase occurs after the tonic phase and is characterized by the sustained rhythmic jerking of the limbs. So generalized clonic seizures and generalized myoclonic seizures are associated with irregular and not necessarily synchronous bilateral jerking. Generalized myoclonic seizures, myoclonic tonic-clonic seizures is a new seizure designation begin with irregular jerking on both sides followed by a tonic-clonic seizure. Myoclonic tonic-clonic seizures are common in juvenile.
Myoclonic atonic seizure. This is also new seizure designation and are characterized by initial irregular jerking followed by loss of tone on both sides. These seizures are common in epilepsy with myoclonic atonic seizures like Lewis syndrome. We have atonic seizures. These are brief and occur when there is bilateral loss of tone and muscle become limp. The patient is standing when the seizure occurs. He or she will fall, often resulting in injury. Lastly, we have epileptic spasms. These are also brief and typically occur in clusters with flexion of the trunk and flexion or extension of the limbs. Non-motor or absent seizures. This includes typical, atypical, myoclonic, or eyelid myoclonia. First, we have typical absent seizures. This present with a sudden cessation of activity, sometimes with eye fluttering, head nodding, or other automatisms, followed by an immediate recovery. EEG always reveals generalized spike wave activity during the seizure. Next, we have atypical absent seizures. These are similar to absent seizures but have other features including slower onset, prolonged recovery, and more pronounced changes in tone. Next, we have myoclonic absent seizures that begins with pure irregular jerks followed by an absent seizure. And lastly, we have eyelid myoclonia that is defined by the jerks of the eyelids and upward deviation of the eyes. Light and closing of the eyes can precipitate these generalized seizures. Eyelid myoclonia with absent seizures is seen in Gibbon syndrome.
Unknown seizures. So seizures of unknown onset can be classified by motor, tonic-clonic, epileptic spasms, or non-motor, or otherwise known as behavioral arrest presentations. So if information is inadequate, or if the seizure cannot be categorized at all, then that means the seizure is considered unclassified.
For the updated epilepsy classification, this is the 7th level of classification and it assumes the patient has epilepsy as defined by the previously discussed updated definition. So this is predominantly determined clinically and it is either generalized or focal, but with this section we'll be focusing on the two new categories, which is the combined generalized and focal epilepsy and the unknown epilepsy. For the generalized epilepsy, this is one or more of the generalized seizure types, and the EEGs typically display generalized spike wave activity. So other data are needed to determine whether epilepsy is generalized, and myoclonic jerks and pertinent family history are used to support the diagnosis. For focal epilepsy, this is one or more focal seizure types that is either unifocal or multifocal, and focal EEG findings like focal slowing or epileptiform discharges are not always seen. Then the concordant focal MRI findings are to support the diagnosis of focal epilepsy. Then for the two new categories, for the first one, the combined generalized and focal epilepsy, this is focal and generalized seizures, and the EEG may reveal both findings from focal and generalized seizures. So example of this would be the Dravet syndrome, which is a severe epilepsy with frequent prolonged seizures often triggered by hyperthermia, developmental delay, speech impairment, ataxia, hypotonia, sleep disturbances, and other health problems. Another example would be Lennox-Gastaut syndrome, which is a severe epilepsy that typically becomes apparent during infancy or early childhood. Affected children would experience several different types of seizures like atonic, tonic, and atypical absence seizures. So for the second one, the unknown epilepsy, this is defined as epilepsy by the ILAE but remains undetermined whether focal or generalized epilepsy. So there is an available EEG and it may be indeterminate. Then the MRI and family history are also not available.
New classification of epilepsy syndrome. So this is defined as the cluster of features and incorporating seizure types, EEG, and imaging features that tend to occur together. So the factors that contribute to epilepsy syndrome are age of onset, remission, triggers, diurnal variation, intellectual and psychiatric dysfunction, EEG findings, imaging studies, as well as the family history and genetics. So it has a social effects and can be associated with other comorbidities. It has also no usage of a self-limiting factor. Here are the three subcategories of the new classification: the idiopathic, reflex, and the focal epilepsy syndrome. Idiopathic or genetic generalized epilepsy syndrome. So the EEG for this has a normal electrographic background and has a characteristic of generalized spike wave findings. So here are the four subcategories of this idiopathic genetic generalized epilepsy syndrome. So for the first one, the childhood absent epilepsy, it affects neurologically normal girls more than boys, and it is a self-limiting. Onset is usually between 4 and 10 years of age, with a remission usually occurring in the adolescence. So patient presents with absent seizures and occasionally with generalized tonic-clonic seizures. So early occurrence of this can be associated with poorer prognosis. Next is the juvenile absent epilepsy. Onset for this is adolescence and early adulthood, with peak onset between 10 to 13 years of age. Girls and boys are affected equally. Absent seizure occur less frequently than in childhood absent epilepsy. So generalized tonic-clonic seizure occur early in the presentation, and it has myoclonic seizure, although rare, it also may occur. So this syndrome is not a self-limiting. So here also are the EEG findings.
Reflex epilepsy syndromes. This is elicited or provoked by a specific stimulus. So the most common type of reflex epilepsy would be the photosensitive epilepsy, and this also includes other examples such as reading epilepsy and as well as the startle epilepsy. So for the focal epilepsy syndrome, there is this thing called childhood epilepsy with central temporal spikes, wherein this is just a benign epilepsy and it is a self-limited epilepsy which is experienced maybe in about during the school years, and there is normal with sleep activated central temporal spikes. For the Panayutopolis syndrome, it is self-limited epilepsy as well, wherein this is often prolonged and have a focal occipital high amplitude sleep activated type of seizure. It's an autonomic seizure, and the symptoms include vomiting, pallor, mydriasis, cardiorespite, gastrointestinal and incontinence, as well as thermoregulatory symptoms and hypersalivation.
Etiology and risk factors for epilepsy. So there's two of them. First is there's a genetic cause, and the second is a structural cause or metabolic cause. So the genetic cause of epilepsy is a result of a known or presumed genetic defect in which seizures are the core symptom of the disorder. So first-degree relatives with epilepsy account for 15% of the cases, and in these 15%, 75% of these cases have just one affected relative. So the risk is higher with first-degree relatives of patients than in the general population. So the common features are variable in family history, generalized spike wave abnormality on the EEG, onset in childhood or adolescence, and there's also a susceptibility to these seizures that most likely results from an inherited biochemical membrane or neurotransmitter defects that result in abnormal excitability within the involved circuits. So for those that want to refresh their memory regarding neurotransmitters, they're basically the chemical messengers, right, in your brain to your other neurons and to the neurons of the muscle. So, we probably talked about Parkinson's before, which is a disease that's very relevant in our neuro topic. Parkinson's, of course, being a disease in where the dopamine pathway is affected due to degeneration in the substantia nigra, which is the part of the brain that produces dopamine. So just a little refresher. So in most epileptic cases, the data is most consistent with polygenic influences, although mutations in single genes account for a few but rare epileptic syndromes. So complex disease genes accounts for 50% of all patients with epilepsy, and neurodegenerative disorders, inherited malformations of cortical development, and inherited metabolic disorders may underlie the onset. So this is a table for the mutation of the genes and the seizure type that structural or the metabolic causes of epilepsy. So these are multiple, and the symptoms may be transient, which means it can be resolved after treatment of the primary disorder. So this can be caused by any major category of serious disease or human disorders. So for example, congenital malformations, infections, tumors, vascular diseases, degenerative diseases, infections, and injury. So people who are older than 50 years old, so for those people, CVA is the most common cause for epilepsy. Following, this is not only the most common cause of epilepsy, but it also increases the risk of seizure by 17% following a stroke. So it is also stated that seizures can be the first symptom of an intracranial mass, and 10 to 15% of older adult onset epilepsy is a result of a neoplasm. And if it is due to a permanent lesion or a scar, the seizure activity may persist. Also, head trauma is the most common preventable cause of epilepsy. Subdural hematoma can cause seizures, and it is common in older adults, even after a fall that may seem trivial. So pneumonia can also carry the possibility of hypoxia, cause seizures to be recurrent. And also for those people that like to drink alcohol, please drink moderately, because alcohol abuse can also cause seizures, as well as hormonal changes. So an increased level of estrogen during ovulation and menstruation. So these are the potential causes of acute symptomatic seizures.
So incidence of epilepsy is referred to as the number of new epilepsy cases during a certain time. Incidence, on the other hand, is the number of new cases among vulnerable people in a given place and during a specific time period. Incidence studies give a better knowledge of the etiology and natural history of epilepsy in contrast to prevalence studies. So epilepsy incidence studies, on the other hand, are scarce and inconsistent. The proposed 2017 epilepsy classification establishes a framework for defining epilepsy, epilepsy syndrome, and etiology in greater detail. The emphasis on etiology may lead to a better understanding and determination of epilepsy incidence. The utility of the newly proposed system will hopefully be clarified by universal implementation of this classification system and further research. Seizure and epilepsy classifications have evolved since a system was first introduced by Gastaut in the late 1960s. The 2017 ILAE classification of seizures, epilepsies, and epilepsy syndromes aims to group seizures according to clinical presentation and brain region onset, and epilepsies according to seizure type, age of onset, probability of remission, EEG findings, radiologic findings, and genetics. Several international research have reported a wide range of outcomes with significant variation. Further studies needed to evaluate the utility of the 2017 classification system. Potential variability in coding and poor agreement among physicians may limit its use.